This is a group of my mentors, and I always include this slide when I give talks because these are the people that I learn from, and we're all learning, and it's a safe environment and an environment where we can support each other. So a lot of these faces, certainly in London, are familiar. You can see that from the top right, that's Dr. William Abbott, through across the middle line, ending with Dr. Kerr right beneath him. These are the surgeons that I work with as part of their team. They mentored me growing up, and then now I'm, honored and delighted to call them friends and colleagues. And, the top row, there's obviously Dr. Marks, a number of surgeons and oculoplastic, periodontists, people from all different, one endodontist, people from all different specialties. And so we always have something to learn and have to go with an open mindset when we're approaching different talks and different avenues. Mike did a great job in kind of discussing my path, but just to review quickly, I went to Western. I grew up in London. There's a photo of me in dental school. I'm looking much more rested and with a lot less gray hair there and happy. I went to USC for dental school, and then my training took me to the University of Miami, Jackson Health System. It's a level 1 trauma center. It's one of the busiest hospitals in North America, and there it was a blast. We did, certainly a lot of trauma, gunshot wounds, the stuff that you would associate with, maxillofacial stuff, but a lot of really cool, interesting things too. As far as bone grafting is concerned, Dr. Marks, my chairman, really innovated many of the principles in GBR, in doing tissue engineering, lots of implants, lots of pathology. So it's really fun to talk about these topics and makes for some pretty interesting discussion. And also, as a resource person, it's nice to have some experience in doing that, not to mention all the pathology, osteoarthritis, necrosis, cancer, and other things we did as well. And then, as I mentioned, currently, I work at Interface. I'm part of the team, and I love it there. And it is really a pleasure to work there every day, along with my colleagues and friends. As far as how Interface is formulated, and I'll be brief with this, but we are composed of clinics and hospitals. So we have a clinic in London, Ontario. We have a clinic in St. Thomas as well. There we do, things such as wisdom tooth removal implants. We do IV anesthesia for patients. We are licensed to practice general anesthesia for the right patient, the right indication. Looking at the hospitals we operate at, we work at St. Thomas Elgin General Hospital, and also Victoria Hospital, LHSC. And in these settings, we're treating more medically compromised patients. We're doing orthognathic surgery, more complicated bone grafts, things of that nature. So it really offers a nice breadth and a nice resource for the dentists in the community that we work with and we support to manage patients that may be a little bit more tricky, maybe a little bit more complicated. And so it is nice to have these outlets. Interface in and of itself isn't just, a group of 8 guys working together as oral surgeons. It's also, we are proactive in educating all of the great doctors that we work with. And we really take a vested interest, and I'm very passionate about this along with the guys, in their development, in learning how to do implants to an excellent level where you feel great that they're, treating their patients with the utmost care, they're learning properly and having great outcomes. And that's not to say that there are other ways to do it. There are, and there's other great places to learn, but we're very passionate about this, and this is what we do. And we have a surgical and prosthetic mentorship program, usually goes on in the summer. Now with COVID, it's been interrupted, obviously, but we will get it back on track once we have some level of normalcy. And these are our course directors. We have Dr. William Abbott, Dr. Kevon Abaste, which many people know, and then Dr. Michael Horniak doing the prosthetic component as well. And then the rest of the team. So everyone's involved, and you can see the list of all of the great surgeons that we have: Dr. Aiello, Dr. Kravitz, Dr. Curtin, Dr. Kerr, myself, Dr. Friedman. So it's really nice because it offers, multiple days of didactic. Then you will watch live surgery, which is cool, and that's important to see it. And most importantly, then you will bring a patient, you'll bring 2 patients on different times, or your patients, you bring your staff, you do the surgery, it's you doing the surgery, but we're working with you to kind of replicate the resident attending sort of dynamic. So if you have an intraoperative question, if there's a technique issue, we can fine tune that so you can really feel confident going forward and tackling these cases on your own. and develop some degree of sophistication. So it's a really cool thing. Many people do this, but this is our take on it, and I think it's pretty special, and it's a fun thing to be part of. So in looking at this topic, I think it's incredibly important to have the right mindset. When we're dealing with complications or evaluating anyone else's work, we have to have the right mindset to have and foster a mindset of non-judgment, because we weren't there in the situation. We didn't know exactly what was happening, if the patient was difficult, if they were moving, how complicated the case was. And so I'd like to put these three principles before we delve into like clinical cases, just to show the approach that I think is appropriate when talking about complications, whether it be my own, someone else's, someone in the communities. So we'll start with this first one from Dr. Cocker. A surgeon is a doctor who can operate and who knows when not to. And that's a hard thing, because oftentimes when we're all pumped up about doing a particular procedure, we've learned something new, we want to use it, however, we have to be sophisticated and learn the proper indication for things to get the optimal result for the patient, right? The second quote here, the second principle: the very first requirement of any clinic is to, do the sick no harm. And that's Florence Nightingale. She is the modern day mother of nursing, who came up with triage during the war and really put patients first. And thirdly, from Earl Nightingale, a popular broadcaster in the 1950s, when you judge others, you do not define them, you define yourself, right? And so that's the mindset that we harbor. You never judge anyone, you just deal with the problem. We talk to the patient, we get the patient out of the bind, and we also talk with the doctor or whoever it may be to find out, what the details were, what the circumstances are, and hopefully to learn and work together that this can be prevented in the future. And I think that's imperative to underline. So as far as the objectives, it's a big topic. I like to tackle it in a three-pronged approach. We're going to go over the high-yield complications, as we mentioned. We're going to go also into depth about the decision-making to try and prevent them and how we can manage them technique-wise to prevent them, and treatment plan, assessment, and prevention. This gets into efficiency. How long, can I anticipate an extraction to take? Is this something that I want to do? I'll book more time for it, or is this something I'm going to refer if I have other cases and other things to do? All of these things together hopefully will yield the maximum impact and value for you. And of course, we're going to be doing it within the context of clinical case discussions, because that's the most useful, to see it in real world examples, right? So without further ado, we're going to start with soft tissue gingival and mucosal tears, soft tissue trauma related with extractions. This is a classic picture. This is common, and anyone who's taken out, any number of teeth has encountered this at some point in time. So as far as what this will cause the patient, the direct result, they're going to have, with any sort of degree of soft tissue trauma or injury that's beyond just doing a flap, they will have increased pain, certainly increased swelling, prolonged healing, compromised aesthetics if it's in the aesthetic region. Nothing groundbreaking here, but things that contribute to a positive patient experience and things that we need to be mindful to prevent or anticipate in the case. Other things that are a little bit more important in addition to that, so longer op time, right? If you make a laceration or a tear in your flap, it's going to take more time for you to put it back together meticulously, aesthetically, so that way when they heal, it minimizes the result. Bleeding certainly is a common issue as well when you have soft tissue tears. The loss of keratinized tissue, this is a big one, especially if you're going to be doing any sort of implant placement after an extraction. Depending on where that tear is, that could compromise the result in the long-term longevity of the implant. It may predispose them to soft tissue grafting if it's very severe, rare, but still something to consider. Also, and this is the most important, vital structure injury. The main one in this instance is the lingual nerve, and can be the mental incisive nerve in the anterior mandibular region. And the reason for that is about 10 to 15% of patients, the lingual nerve has been found in studies to course at or just at the crest of the lingual plate in that region, right? So if you look at the schematic that I've put up for us here, if you look and follow D down and letter E on the diagram, the lingual nerve can be very close to that area. And in this instance, when you see the case on the right, you know, that tear occurred during extraction of the 4-7 tooth, right? So we have to be very careful. And if a tear traverses down into that area, it's a high risk sort of area, and we need to be mindful. I'm going to go over strategies on how to prevent that. The other key things to note, you know, on average, the lingual nerve is about 2.3 millimeters below that crest on average, and about 0.6 millimeters medial of the crest. And in about 25% of patients, the lingual nerve is actually on the lingual plate itself. So if you're taking a burr, for example, to extract a 2-7 and you need to do a little bit of bone reduction, you have to be very careful coming around that distal aspect. I would you know, caution you, just stay on the buccal, stay on the distal buccal line angle, and don't carry it too far medially, because the lingual nerve is in that area and at high risk. So that's one example of how vital structures can be compromised. This is another example, and I apologize for the graininess of the photos, but it's hard to get pictures back there. You can see in both of these instances, you know, they've developed palatal tears. So if you're back there elevating and extracting a molar tooth, okay, and you don't do an adequate periosteal release, you can get these sort of issues. And that's critically important, especially when you're starting out. You have to take time to take the periosteal and circumferentially detach around the tooth. If you don't, you can develop a tear when you're luxating the tooth, or certainly with the forcep. Also, forcep selection is critical. You have to see how the forcep is seated on the tooth and take time to look. Is the beak on the lingual, on tooth structure? Is it on the buccal? You know, in the mandible, in the maxilla? You don't want to be impinging and grabbing soft tissues when you're luxating these teeth. So if you see that, if you see tearing starting to happen, stop. It's a sign that you need to do something different in the case. You don't progress, because you can absolutely, you know, tear the palate, you can tear the lingual tissues or in the mental region. Go back to the periosteal, detach the tissue. If it's really bad and you feel, you know, uncertain or worried, you can always, if you have a good relationship with a specialist, and we'll talk about ways of doing that, give them a call or refer to the patient over, whatever you feel is appropriate. However, the best thing you can do is stop and evaluate the situation, work through it, and the patient will appreciate that, and they'll appreciate your honesty to do, you know, what's ideal for them. Because the healing, oftentimes these things will heal, but they'll be very uncomfortable. And if it's really bad, then you can get into a nerve injury, you can get into, you know, significant palatal lacerations and things of that nature. I include this photo. This is somewhat unrelated to extractions, but this goes to show kind of the difference in the tissue. So we always, you know, we're inclined to think, and rightfully so, the palate is more robust. It's very thick keratinized tissue. This is an image from residency, you know, during a maxillary expansion, where, you know, the maxilla was kind of overexpanded by another surgical service, and they developed a dehiscence, a hole essentially in their palatal tissues. And so although it is robust, we still have to treat tissues with, you know, the utmost respect, care, and proper surgical technique to prevent this, because nothing in the oral cavity is bulletproof. The tissue is very, very thin, as we all know. So just to review some of the key points that we were talking about to try and prevent these from happening. Fundamentals. The number 9 periosteal elevator, your periosteal, spend the appropriate amount of time and attention. Make sure you're circumferentially getting around that tooth, especially when you're starting out. It cannot be underlined enough. Proper forceps selection and seating, right? Make sure you're on tooth structure. You're moving it apically, but you're not impinging any soft tissues. Appropriate forces during, you know, elevation and luxation. Really, to take out teeth does not take much force at all. It's all about, and when people say that, what do they mean? They mean getting a purchase point, right? As you were taught in the oral surgery clinic in school. You want to put the elevator in, and if it's in the right position, oftentimes you will see the tooth start to move. And we'll go over some of the fundamentals of elevation and how you can do that more effectively. Observation during extraction. This is also paramount. So really watch what you're doing. See the result of your actions with the forcep, with the other instruments that you're doing. And when you're seeing things go awry, stop and reassess the situation, right? And then move from there, whether it's changing the instrumentation that you have, calling a specialist friend, referring the patient, whatever it needs, you need to do, you have to intervene and stop the action because it's leading to an undesirable result. Appropriate incision design, length, and releases. So there's an adage in surgery that was taught to me that I love, an oral surgery adage: see well what you do, so you do well what you see. So if you're anticipating, tears and things like that, it's okay. Just make a release so that way the tension is off of the tissues. These are fundamentals that we go through with our implant mentorship and other things, like other CE and stuff we do. But this cannot be overemphasized enough. You have to have appropriate release and appropriate visualization to make sure you're doing a good job for the patient, whether it's an envelope flap or an envelope with a little release at the end. You have to do that to take care of the patient. Gentle retraction. So all incisions will tear to the appropriate size, right? If you don't have enough release, or you're really, you have that kung fu grip and you're really being hard on the tissue and you're not resting your Minnesota on the bone, you will tear the tissue, your flap to the appropriate size that it needs to go based on the force you're exerting, right? So oral surgery is a very gentle sort of specialty with the right technique, and it's fun to discuss these things and to help people learn and grow. This is the proper way to hold an elevator. This is the elevator itself is one of the most commonly misused instruments in oral surgery and in dentistry in general, right? Another way that you can get a tear is slippage. It's that simple, right? So if you're holding the elevator here, it's very, with that kind of, fulcrum modified pen grip sort of thing, you have complete control. There's no way that you're going to slip. Sometimes when you're going quickly or your mind doesn't go there, but on average, this is how I hold the elevator, and you can get, good torque on the tooth itself gently, and you'll ensure that you have complete control. It won't slip. This is another common thing that is possible. So if we look here on the left, we have a soft tissue laceration of the lip, and on the right, we have a thermal injury, a burn, right? So oftentimes on the left, this is attributed oftentimes by wearing loops. Now, I'm an oral surgeon that wears loops during oral surgery. I think I like it. I like to see really well what I do. A lot of general dentists who do oral surgery wear loops too, and periodontists, I think it's great. You don't have to, but that's my preference. Sometimes though, when we wear loops, we can have tunnel vision, right? So we're focused in on that little area that we're working on, and you have to be incredibly careful when you're using instruments, when you're, doing procedures, that you're mindful of all of the surrounding soft tissue structures and architecture. So oftentimes that's how lip injuries occur that I've seen, in training and from referral. The other thing too, I should mention, and we were talking a little bit about staff in light of COVID before, is it also contributes to needle stick injuries with assistance. So you have to be very cognizant to, look out of the loop, and when you're getting instruments back and forth, putting them on the Mayo stand, whatever you're doing, that you're taking your time and slowing things down to do it appropriately. As far as thermal injuries, if you're using a drill, take mind of the heat of the drill. Little things. You can put it in water, just, wait and allow things to cool down. Don't necessarily have a tunnel vision. You can avoid injuries like that as well. So interop and delayed bleeding, another common complication and interesting. So when we get into bleeding, we always think about the source, right? What is causing the bleeding? It's anatomically driven, right? So you have to think about the structures, okay, that are involved and what we're altering to achieve the procedure, right? So it's typically bone, soft tissue are the main two, and we'll get into some other ones as well. So if we start with bone, okay, we've all seen this cross-section of bone in textbooks and things like that. We see the Haversian canal system there. The periosteum as well can also bleed. And the periosteum, for new graduates and stuff, you can kind of think of it as like saran wrap that overlies all of the bones in our body, essentially. The periosteum itself is a tremendous source of blood supply, and it's also, imperative when you're doing more complicated bone grafting techniques and things like that. Managing the periosteum, as far as getting a beautiful release on your flap, a submucosal dissection, which is critical. You're working with the periosteum. Periosteum can bleed, right? In addition, we're talking about other soft tissue structures. The posterior superior alveolar artery is of critical importance. So this is a branch off the maxillary artery, okay? And where can we get into this? Well, if we have a buccal plate fracture, let's say, of tooth number 27, when we're doing an extraction and it goes high enough, you can absolutely get into that vessel, right? If you have a tuberosity fracture, when you're, with a fully erupted third molar you're trying to remove, let's say, you can get into that. If you have a soft tissue tear, less likely, but you can get into it. This vessel, you'll see, is usually in the bone. And I've included these. I love these images because it shows where the vessel is. And you can actually see it if the patient has a prominent one in cross-section on your CT, right? So you can see where the arrows are illustrating it. The other instance that you can get into it is with a sinus, a lateral window for a sinus lift, right? If you're grafting in the area of the 2.7 or if it's really anterior to the 2.6, let's say, you can absolutely get into that vessel. Typically it's not catastrophic, but it needs to be managed because it will continue to bleed, and certainly it'll be annoying at a minimum. So you have to feel comfortable in managing these things. Discussing them is important. And being aware of them is important, right? In the treatment planning of cases, if you see this, maybe this is a case you work on with the oral surgeon, or you call them and have that dialogue so you're better prepared. There's many ways to achieve, a great result for you and your patient, and for you to learn and gain mastery and feel confident. Another source of bleeding. So the inferior alveolar nerve, it's truly a neurovascular bundle. If you get into this nerve, or this neurovascular bundle, I should say, with an osteotomy, let's say with an implant or with an extraction, and I'll show you some of those cases later on, it will bleed, and it will bleed in pulsatile fashion because it is a neurovascular bundle, right? So that's the telltale sign. The telltale sign is pulsatile bleeding of the IAN. And there was a great sort of principle that was taught to me as a resident that I'd like to share with you. So, you never want to poke the bear. Basically, it's meaning that take the case beforehand. If it's a relatively high risk sort of thing, spend the time preoperatively to assess the case and do what you need to do, whether that's more planning, whether that's referral, whether that's working in conjunction with a specialist. There are many ways to do it, but you may get away with it and it may be fine. Or, if you poke the bear and the bear is agitated and comes after you, it may not be the best situation. And so most nerve injury in general, most of these sort of things, whether for bleeding and certainly for nerve injury, are avoidable, right? Especially now with technology to see on a cone beam CT, there's an ample amount of CE as well, certainly with us, but other sources as well. This can be prevented by and large. It just needs study and appropriate time to think about the case. How about the facial artery? So this is one that's less common. Typically, when this is lacerated, it's from slippage, right? And where that is it kind of comes underneath the mandible. It comes up, and you can see kind of where it crosses between the first and second molar, and it terminates at the annular artery there by the nose, right? So if the patient moves, for example, if they don't have adequate anesthesia, or it's a patient that needs neurolept anesthesia, IV anesthesia to be comfortable because they're very nervous, right? If they move and the instrument slips or goes down in this area, it's rare, but you could absolutely lacerate that vessel. When it bleeds, it does bleed at a fairly good clip. To give you a point of reference, the facial artery is what's used oftentimes when we're doing free flap surgery for large composite reconstructions, free flap where you're taking tissue from the leg, let's say, and reconstructing parts of the face or inside the mouth by microvascular surgeons. They'll anastomose, connect the vessels from the facial artery to the artery in the flap. So it is a robust artery. It does bleed, and it does need to be respected. Very rare, yet again, but it is something that we have to consider when we have sharp instruments in the mouth and we're working in that area. This is another one that's really interesting, but very subtle. So if you look here, this is an AV malformation, right? And it can mimic pathology. So it looks like almost like a cyst down there or some sort of intrabony lesion. The issue with these is when you feel them, they're often pulsatile. So that's the giveaway. If it's pulsatile, okay, and they say in books that you can hear a bruit sometimes, but that's more esoteric and difficult to ascertain. The main thing is it's pulsatile, and they're rare. I've only seen two. I've seen one in the maxilla and the palate, and one in the mandible. However, if you get into it, let's say you're going to extract, the 4-6. You can have devastating bleeding, and this is bleeding that can, cause a significant amount of blood loss that is kind of in the scarier territory. If you look at this patient here, the treatment for this is a CT angiogram. So we send the patient to CT angio, and then they'll go to interventional radiology, and they'll embolize that vessel. So at which point then, we can do the extraction or, whatever the patient needs oral surgically. However, that step needs to be done first, and that's their main problem, not necessarily the caries on tooth number 4-6, let's say. Ours is important too, but in the grand scheme of things, that's their main problem. So they'll go in and kind of tamponade off that vessel, and then it'll be safe to proceed. This is another common one that's interesting. So this is a liver clot. So typically, say you do an extraction on an older patient, they're often anticoagulated on aspirin, on Plavix, let's say, and they complain of chronic bleeding that is going on for days, and despite pressure and whatnot, it's still bleeding and bothersome and annoying to them. Likely they may have a liver clot, and this will continue to bleed until it's removed. So this is a common thing, especially in the elderly and especially in the anticoagulated patient that you're likely to see. Another one that's common, especially for intra-op bleeding, and it's a simple one, is granulation tissue. If we think about the reason why we extract most teeth, it's due to chronic caries. It's due to long-standing infection. If you look at what granulation tissue is composed of, it's blood vessels, endothelial cells, right? They have a propensity to bleed because they're forming, fibroblasts in the area, and macrophages and neutrophils. So the best way to stop bleeding intra-op, if it's from this source, is just to remove the granulation tissue. The same way you put emphasis and time into your periosteal step, you should put into doing a very good job in curetting out the sockets. And that's something we do routinely, and something, it's fundamental, but you need to spend time doing it, right? And it's always a good review. So let's break up the monotony a little bit. I think it's important, just to keep interest and whatnot. So, we've been going through this quarantine together. It's been kind of boring. We've certainly been doing a lot of walks and exercise at home. I got a Peloton, and it's been, something I can do at least to have a little bit of fun, and it keeps me active. Certainly a lot of family time on our hands. Most of our families hopefully look like the left side. I feel like most families, though, are on the right side on their phones and whatnot. That's okay. There's no shortage of webinars and CE and reading and stuff like that. I think our community has been very good at fostering that sense of community and making the most of this time as best we can. And then, all the PPE and regulations from the college. I mean, there's been so much reading and stuff that's been done on this. It's really remarkable, and hopefully we'll be back to some relative normal soon. And television, there's been no shortage of entertainment that we can watch. There's one show in particular that was particularly that struck a chord with me, that was poignant, and that is The Last Dance. If you haven't watched it, it's certainly worthwhile. It's an awesome documentary, even if you're not a basketball fan. There are many parallels and fundamentals in life, in professional life. So much so that it prompted me really to think about, Jordan and professional athletes. And I thought to myself, they're very similar in a way to we are as doctors. If you look at Jordan, and professional athletes in general, they assemble around themselves a professional team, a team that maximizes their efficiency and their productivity. They have a personal trainer, they have an agent, they have a coach, they have an accountant, tax attorney, all of these people to maximize their success. If you look at us as dentists, we have largely a lot of the same sort of things in overlap. We have an office manager, we have an accountant, we have, all of these people that are here to help us and maximize our efficiency. And that takes care of the personal aspect of what we do. Professionally, Jordan also had a team. He had his teammates, and through his teammates, he was able to distribute the basketball based on his discretion, based upon the game situation that he was in, to win, to build an awesome legacy in a team. And in the same way, we also have a team, right? The dentist can distribute the patient based on their discretion, based upon what they're trying to achieve in the certain situation to win. And so obviously, you know, they won six championships. They won, you know, and for us, really what, you know, I was thinking, like, when preparing for this lecture, what does fulfillment and winning, so to speak, look like, you know, for our profession? And I really distilled it down to three points. And this is, you know, my personal belief, but I think it's important to share with you and keep it in mind in reference to the topic at hand, which is complications and really trying to learn and grow. So, you know, one, we want to take care, and this is pervasive to all dentists, dental specialists, everyone. We want to take care of patients effectively. We want them happy. We want them glowing. We want them satisfied. Secondly, we want to push ourselves. We want to challenge ourselves professionally. We want to feel fulfilled. We want to feel satisfied with what we're doing and excited. Thirdly, financially, and that's reasonable. We want to build a great practice. We want to have a business. You know, a lot of people are after a particular lifestyle. All of these things together can work in harmony. And, you know, through this team and this team approach, you can absolutely give patients the best. You can leverage these connections and these relationships to learn and expedite and accelerate your learning. And you can offer more to patients. And really, you know, another thing that kind of struck a chord with me when I was in residency, one of my attendings always said, the number one thing that you have, it's not how big your practice is, it's not how many patients you have or the procedures you can do, it's really your reputation, right? Your reputation, as I was taught, and I believe, is really the compounded aggregate of all the decisions you make, right? So, and you can have a good reputation, a great one, or you can have a bad reputation. And it's also variable, it can change. But every decision we make as providers is really casting a vote towards that reputation. If you compound good decisions, you know, for your patients, you're doing things that last a long time, that are reliable, you're treating them well, which, you know, the vast majority of dentists do, you know, you're gonna establish trust, right? And that is the most important thing, especially for the young graduates, and that's why I included this. Establishing a sense of trust with your patients is paramount, because they're going to trust your diagnostic skills. They're going to trust your ability, you know, when you see a problem, when you offer a fix to them, they'll trust that the fix is going to work and that it's what's best for them. If you refer the patient, they're going to trust that that's the ideal treatment for them, and you're going to work with someone hopefully that treats them with dignity and respect and really wants to work in lockstep with you. If you're going to monitor them, they're going to trust that that's what's best for them too. And that's really the essence and the best internal driver to bring patients to your practice, in my opinion, and make you feel fulfilled and successful and happy. And it's the best form of internal marketing as a byproduct. Not that we do it for that reason, but that's a byproduct of that. You know, and so I think that can't be underlined enough. So in relation to that, and to that end, you know, how can a young dentist or a dentist who's interested in oral surgery, or someone who's advanced at oral surgery, really get the most out of their specialist relationship? And there are many dentists that we work with that use these 6 points that I kind of put together, and there are many that haven't yet come to that realization. That's okay too. There are many ways to be successful and to work together. What I think is, you know, you want to find the right group or the right person that will help me learn. So, you know, it's very important that the dentist is supported through continual growth and development. And, you know, we have things like iDisc. There's no shortage of CE and things like that. But I think that's a fundamental thing that you can be looking for if you want to work with a specialist, to leverage their knowledge and really learn faster and accelerate your development. Secondarily, you know, working with a specialist can amplify what you offer to your patients. You can work more efficiently. You can take on more complex cases. Your cases have more predictability in a lot of instances, and that's paramount. Predictability and trust are interlinked. So if what you offer patients long-term, works and they're happy with it and it's aesthetic and it's functional, they're going to trust you and they're going to bring more patients, you know, in your door and want to do more work with you as well. Thirdly, reduces your Tylenol factor, right? You know, working with a specialist, the right group that works in lockstep with you, can take care of complications, can take care of things that you don't necessarily want to do if you don't want to do them, can work with difficult patients, and you can leverage your time in that way to focus on what you want to focus on within your practice as you see fit. Fourthly, has my back. That's critical. When things don't go as planned, it's always great to have backup. And things don't go as planned and everyone has complications, right? So it's good to have a friend in that support system. That'll reduce your liability. It'll increase efficiency. You know, we're always reliable, always and in all ways. At Interface, we have an adage, you know, we're open like 7-Eleven, right? So, you know, it's incredibly important to have that connection and have someone that will go out of their way to help you once you establish that working relationship with them. You've done cases with them, you've called them, you establish that rapport. You know, they'll do what it takes to protect you should things, you know, come to that or what have you, to navigate those difficult situations. Communicates well with me and helps me convert dental treatments. That's also important. You know, when we see diagnosis and things, we recommend to the patient, you know, if it's on the treatment plan, if it's, you know, will help them, we work in lockstep and communicate with the patient, and they're hearing the diagnosis, they're hearing possible treatments from different sources, as long as it's in line with the plan, the treatment plan of the dentist. We absolutely support that, and we will you know, follow suit to reiterate that, you know, where appropriate with the patients. And that's a very integral point that I think is not leveraged enough. And lastly, lifelong friends and colleagues, right? It's really a wonderful fraternity and sorority to be part of in dentistry, in oral surgery. And some of my best friends in the world, you know, I met through dentistry, and we have dentistry in common, but oftentimes we have a lot more in common outside. You know, we're similar personalities. And so working together is great, and also spending time together outside of work. And I do that all the time. I meet, you know, doctors for coffee, and we have dinner together, and it's really a wonderful fraternity and sorority to be part of. So getting back to our topic at hand, let's go back to alveolar and basilar bone fractures. So a couple of photos here. These are common photos, which, you know, are fairly relatively common complications. And essentially, you know, how can this be prevented? Adequate luxation, okay, is incredibly important when you're approaching a tooth. Looking at the root anatomy, okay, and the bone. If you take a cone beam CT, you can look at cross section of the bone. As well, to anticipate difficulty. If you see splayed roots, let's say, or you see, you know, a really thick canine fossa, a figure of 8 motion is what I tend to use to remove these. Now you can do a little buccolingual as well, whatever you feel comfortable with. As you do more, okay, you'll develop in residency what we call a hand. So you'll start to feel the tooth move through the alveolus in atraumatic fashion to not, you know, fracture the alveolus in most instances. And be gentle, right? It's all about technique. It's all about seeing the forcep appropriately, as apically as possible, and doing that figure of 8. If you look at this implant case, I included that as well, because oftentimes, you know, what's best for the patient sometimes is to elevate a full thickness mucoperiosteal flap. And that way you can see the root structure, you can see where you're going to place your instrument better, and you can remove the tooth more completely. This is an article that I wrote in residency as well, and I think it's really good, especially for young dentists getting into, you know, doing some oral surgery procedures. It's called the millimeter mindset. And so in this sort of macro world of extractions and, you know, different procedures, comparative to the micro world of doing crown preps and fillings and whatnot, we need to be able to jump back and forth between, you know, the macro and the micro, and still keep in mind a lot of those very seminal, very poignant micro principles, like keeping, you know, keratinized tissue, ensuring that there are, you know, in the implant world, making sure that there are no dark triangles, and we're respecting a lot of the periodontal principles, in addition to, you know, the oral surgical principles. So we were talking before a little bit about the posterior superior alveolar artery, and we were looking at oral antral communications and bleeding. Those are the two main biggest problems with fracture of the alveolar bone, especially in the posterior region, right? And we also address nerve injury as well. And again, the vessel, as I mentioned, certainly can be involved with fracture of the bone. This is another example here of a tuberosity fracture. And as I was mentioning before, when you're elevating the site, really pay attention and palpate. Put your finger on the buccal, put your finger on the palatal. If you feel the bone starting to move, you can anticipate a tuberosity fracture. And for the aforementioned listed reasons, oral antral communication or bleeding, lack of healing, increased pain, we want to avoid these things. So if you start to feel that happen, take time, use the periosteal, ensure proper detachment of the surrounding bone, soft tissue. If you're unsure, if you're uncertain, you can always refer the patient over to an oral surgeon, and then the patient will be cared for, and then we can walk through ways to prevent that in the future, so they have the best outcome possible. So yet again, stop and examine what's happening. Take a critical assessment of what you're seeing and make a definitive action to improve the result as it's happening. This is another example. It's rare, okay, but it's also very common in the sense of third molars with extreme force. This is a mandibular fracture, which is subtle, and essentially what happened was there was too much pressure that was put onto the tooth during elevation, not adequate, bone reduction. The patient was moving, was a difficult patient. They required IV sedation to be comfortable, and this was done under local. And they wound up with a mandibular fracture, and in turn had to have a plate put on to fixate this segment. And that's not an ideal result. So this can be avoided just with the proper preoperative examination and thinking about the case. This is another high-risk case that's very common, and it's very fashionable nowadays to do, all on X sort of procedures, and you see it on Instagram and all this stuff. But these cases are amongst the most difficult for many reasons, but this reason in particular. So if you see this presentation, this is your classic atrophic, bucket handle sort of mandible. And the patient will come in and they'll be complaining of, ill-fitting dentures. They'll want a relatively fixed solution or a fixed solution. And, you can see in this area how thin the bone is. Well, in this instance, the patient was referred to us. The implant surgery was attempted, and the patient wound up having bilateral mandible fractures. So that in turn correlated to, taking them to the operating room, unfortunately, a neck incision, 2 plates placed. You have to rigidly fixate this sort of mandible. So we have to use heavier plates because it's so thin. And once they healed, we were able to go back in, take the plates out, and then do the all-in-4 on the upper and lower. But with these sort of cases, I'm not saying don't do them. You absolutely can do them, but there is nuance to them. There is technique, and you would be, best suited really to work in conjunction with, specialists who are passionate about full arch and really enjoy it, and learn from them and do cases with them, and you can go from there. Another thing I'll point out too, you can see the arrows in this instance. With atrophic mandibles, you will see as the bone resorbs, the mandibular canal with the neurovascular bundle in it will rise up to the top. So you cannot make a crestal incision on these areas where the arrows are, because you will incise the nerve. You will cut the nerve. So you have to be very fastidious and very careful in your dissection when managing this area and this type of patient as well. This is a nice little algorithm that I put together that I really like, that kind of helps you triage, helps you treatment plan and think about cases as far as extraction difficulty. And you can use this to allocate time, you can use this to refer, you can use this for instrument selection, and I think it's really valuable. So if we look at this, the standard tooth for extraction, right? Let's amp up the degree of difficulty though. So it's gonna mean for a far more challenging and difficult extraction if the patient has advanced stage. Pretty basic, but they're gonna have upregulation of the bone that's laid down. It's gonna be much more dense. if you see things like mandibular tori or exostosis, this is indicative of increased internal loading of the bone. They're clenching, they're grinding. The bone is going to be much more dense. The tooth is going to be harder to come out. In addition, if we add to that, okay, a tooth that's heavily restored, it's brittle. The leverage that you're going to have is going to make it far more difficult, right? An endo-treated classic sort of tooth like this, it fractures, it's more difficult. You're going to have to put more time into it, and you can either schedule that in your schedule, or you can refer, or you can treat it however you want to. In addition, one thing I'll add to this is a standalone tooth. So if we take all of this considered and we have a standalone tooth, especially in the maxilla, okay, is a high risk sort of tooth for buccal plate fracture, oral enteral communication, and it's just more difficult to remove because that tooth is always being internally loaded and the bone is very upregulated around it, right? So just hopefully helpful tips to consider in your evaluation, your treatment planning of these cases and how you approach them. So a couple other things, we'll kind of go through this quickly, but still important. So extraction of the wrong tooth, luxation of adjacent teeth, damage to adjacent teeth, and fracture of the tooth being extracted. Sometimes that can't be prevented, right? Especially in the instance of the endo-treated tooth. Sometimes teeth break, and that's okay. You just have to make sure that you remove all of the parts of the teeth and don't leave any behind. So if we look here, for example, the wrong tooth extraction, it's, in this instance, we've taken out the wrong tooth. Thank God in my career it hasn't happened because I triple check and I encourage everyone to do that, but it is common and it does happen, right? So what can we do to manage this if it should occur? Okay, number one, be open and honest with the patient. That's the number one thing. Tell them what has occurred. Discuss how you're going to rectify the situation. You need to have a solution. Not just what happened, but have a solution, how you're going to manage it. Are you going to do an implant? Are you going to refer the patient? We need to have something to help that person out. Contact your insurance provider and your legal channels. If you have a friend that's an oral surgeon or a specialist in your corner, call them. If you have that rapport, they're going to want to help you and do everything they can for you. And have a process, and this is also imperative, have a process for prevention to learn from it, right? So things such as, when you see the tooth, you're going to call it out and your assistant is going to reiterate, that process. I always check 3 times, check 3 times, cut once sort of thing. So that way this, hopefully can be prevented. In addition, there are different things like the surgical safety checklist. I actually made one for our oral surgery clinic at USC. I think it's still used. And you can make a surgical safety checklist as a good practice if you think it's helpful, in your offices. And this is kind of a cool book that I read, the Checklist Manifesto by Atul Gawande. He's a general surgeon and esteemed author for the New Yorker. And he kind of goes over how to make a checklist, and it's just good reading during quarantine and something to consider. So as far as extracting a tooth, this is just kind of a little pearl, but I think it's important. We were talking about the elevator and the grip of the elevator. In addition, how you use it properly and appropriately, you always want to extract the tooth in this way. You want to rotate the elevator into the tooth that you want to extract. It's counterintuitive. Most people actually do the opposite, and they're doing a scooping motion, right? But what that does is not only luxates in this instance, the 3-6, it'll luxate the 3-5 as well, because you're lever actioning on the tooth. You want to gain a purchase, meaning kind of wedge it in there between the bone and the root, and rotate into the tooth that you're wanting to extract. And in this way, you'll be using the instrument properly, along with the appropriate grip, as I showed you before. So, and that's kind of reiterating what I just said. So otherwise, if you're not doing this technique, you will luxate adjacent teeth. This is how you will most commonly get damage to adjacent teeth, root structure, as well, by lever actioning. Also the opposing teeth. So when you start learning exodontia, everyone's really rough, right? There's a good expression that anyone can extract a tooth. You absolutely can extract any tooth you want, but you may bring the alveolus and a ton of soft tissue with it, right? So you want to be gentle, and you want to ensure that the forceps seated, but not only that, when you're taking the tooth out, you don't want to bang into the opposing, because you can cause all sorts of, fractured restorations, damage to tooth structure. You want to have some elegance and finesse, and having friends in specialty or more experienced people can help you with that, and the motions to use. And you get a lot of that in dental school too, but it's always good to expand your repertoire. And the fractured of teeth, fracturing the tooth you're extracting, sometimes it's unavoidable, but you have to remove all of the pieces that are in there and go after them and get them out. So things like this, it's never okay, really, in my opinion, to leave half fractured teeth in there. I put asterisks there because if, there's a tiny, tiny root tip, like right above the nerve, maybe that's an instance to leave it. But even then, obviously you don't want to cause a nerve injury. In the vast majority of cases, you should not leave it, because we have to think, what is the diagnosis behind why the tooth is being extracted, right? It's being extracted oftentimes due to caries, due to long-standing infection, possibly due to fracture, which is difficult to clean. These are all reasons why we have to remove the tooth out. And if you can't get it out and you've struggled, it's common and it's okay. We oftentimes it's very common to have teeth like this come into our clinic. We help all of the great doctors that we work with, and we say to the patient, no problem. This is incredibly common. Your dentist cares about you tremendously to send you to us, and it happens. We're going to take care of you and everything will be fine. And then we call the doctor too, and we work it out so that way we can, hopefully prevent this from happening. So when that occurs, stop, talk to the patient, make the associate the appropriate, next steps, and it can be managed properly. If it's left, and this, in instances like this especially, but anywhere, it can cause residual problems. And there's a rationale behind why I say, you really ought to not leave teeth behind. It can lead to a submandibular and or sublingual infection. And you can see the schematic that I put there, right? And that can translate to a neck incision, which we've done and I've seen, and Penrose drain placement, and the patient being intubated possibly overnight for airway protection because of a bad swelling, right? If it's left in there. Other things, you're going to have, if it's in there and it's infected, you're going to have a lot of granulation tissue around it. So your ability to put an implant in down the line, or a specialist or whoever you're working with on the case, is going to be compromised. You're predisposing that person to likely needing a bone graft in an infected site. We'll clean it, graft it, put the implant in. But if it can be prevented from the onset, it's going to be way easier for the implant to go in. The patient's going to be way happier, and they're going to appreciate your honesty and you having that network and those assets in your team, like Jordan, to care for them, right? The next topic, and this is kind of related, displacement of teeth and teeth segments. So similar to the fractured tooth segment we saw before, we're seeing one in the sinus now. And again, it's not okay really to leave that tooth in there. In this instance, certainly, but most instances, you should call your surgeon and manage it, right? The tooth there is endo-treated, it's carious. And again, the diagnosis, why are we taking out the tooth in the first place? If the tooth is a nidus of infection, we cannot leave that nidus of infection in the sinus or in a different place where it doesn't belong, right? So, how did this occur? What are the fundamentals here that maybe went wrong? Again, this person is a good doctor. They don't wish any harm to their patient. They're doing their very best. But where can they improve? Poor visualization, right? Oftentimes, make a little flap. See well what you do, so you do well what you see. Awareness, this is critical. Watching what you're doing as you're doing it. You're close to the sinus floor. You have to be very careful. Sometimes it's just teetering on that edge. You have to just be very gentle and have the technique to flick it down. Excessive or inappropriate force. Really, force is really never the ideal way. You want to use the proper technique to get around the tooth and scoop it down if it's a small piece like this, let's say. And look at the tooth. This is another thing that's huge. When you're taking teeth out or whatever you're doing for the patient in the oral surgical realm, examine what you have, right? If you see, you're taking out a molar and you see it has 2 roots on it, there's a root in there left, right? And so you ought to go back and remove it, or if you can't, have the backup, have someone have your back that you can call that can take care of that patient, and you can move on with your day if that's what you wish. So in this instance, plan for management, talk to the patient, be honest, let them know, and then call your oral surgeon and you work it out together and you come up with a plan. Typically in these instances, we'll do a Caldwell-Luck sort of procedure, go in, take the tooth out, and that's it. Go into the sinus, as we learn in dental school, right? And this is what can happen if you leave the tooth in there. As I mentioned, a nidus of infection, right? You can get a chronic sinusitis. And some people may say, well, big deal, the sinus has, inflammation, a little sinusitis, so what? Well, it can actually erode into the nasal cavity. It can erode into the eye. There's a lot of important stuff around that sinus. It takes time for that to happen, of course, but that's not something that you ideally want to be involved with, right? So it's better just to manage it early, get on top of it, and make sure it's managed and you don't have to worry about it. This is a study that I included from our journal, JOMS, that looked at something similar in principle, to eye infections, a subperiosteal or subperiorbital infection leading to rupture of the globe and blindness in this particular subset of patients. It is rare. I've only treated one. However, it is possible if left unchecked. And this is, just to show you, not to scare you in any way, but just to show you the rationale behind why I'm saying what I'm saying. This is another example. So you can see here, the wisdom tooth was pushed up into the sinus. And this is not this person's fault. This is a difficult case. It's not easy, right? So where did they maybe have a misstep? Well, visualization and access, right? If you pushing on the tooth and it's going north, you're not seeing what you're doing. In addition, you need to have awareness, like I was saying, in proximity to the sinus floor, anatomically, and using excessive force and not knowing the appropriate technique. The other thing too, related with wisdom teeth in general, and more difficult extractions, it's not just the mouth, it's not just tips and tricks. I mean, those help and they're fine, but you have to think about the person, in my opinion, behind what you're doing, because you're managing them as much as you're doing your surgery. So especially with wisdom teeth, there is a reason and a rationale why IV sedation, and in particular neuroleptic anesthesia, is the gold standard to remove wisdom teeth. And that's not to say for all wisdom teeth the patient needs sedation. That's not the case at all. If they're fully erupted, or if they're manageable, they're not impacted, or more straightforward, then of course you can manage them under local. But for the vast majority of patients, and certainly here you have horizontally impacted thirds with an eggshell of bone on top, in a nervous patient, which most wisdom teeth patients are, they're most comfortable under neuroleptic anesthesia. That means they're asleep. You get to the sedation endpoint, you have spontaneous eye closure, they're completely comfortable, and they're going to have a great experience. When they wake up, it's going to be done like that in the hands of the right person, and they're going to feel good, and they're going to thank you for it. And the second thing is patient immobility. So they're asleep, they're still, they really don't move around much. So if you need to do technique or gentle, delicate moves, it's much easier to do when the patient is immobilized and not moving around. We weren't there when this tooth was extracted. Maybe the patient jerked and jerked the doctor's hand to push the tooth up into the sinus. We have no idea. But under the right setting with the right patient, you really can't beat a proper neuroleptic anesthesia using multiple drugs, and they're asleep and they're managed properly and very comfortably in a safe fashion. This is just a lateral ceph, just showing that the tooth was pushed up, and we went out and removed it as well. This is what a tooth in the sinus looks like. We give it some time oftentimes, and we allow some fibrosis to happen around it, and that stabilizes the tooth. It makes it easier to remove when you do the Caldwell-Luck. I just put that in there as a source of interest. A next common space where you can push a tooth is the sublingual space. So now we went from the maxilla, we're going down to the mandible, right? You can absolutely push a tooth. It's more rare than the sinus, but you can push a tooth into the sublingual space. If you're pushing kind of down and medially, you can push a tooth, or more likely a root or a segment of tooth. If you're using excessive force, you'll push it through that buccal plate. You'll get it underneath the floor of the mouth, and you can see there 1 and 2, as I've labeled for you, that's where it's going to go. right? It's very difficult and uncommon to push it below the mylohyoid muscle. So, you know, to get it in the submandibular is very uncommon, but certainly the sublingual is possible. And you know, something we have to consider. So again, you know, never medial and never excessive force, not to mention that the lingual nerve is in intimate contact in that area as well. The infratemporal fossa, another place, okay? This is also common. So we went inside the sinus, now we're going outside of the sinus into the infratemporal fossa. The same thing applies, right? So when you see the tooth moving north, if you're doing a case like this, stop. You know, the best thing you can do is just stop, get better visualization, get better access. If you feel nervous, scared, or something is getting unmanageable, it's way better, way easier just to call up your specialist friend or whoever you trust, refer the patient over, and or walk through it, just manage it and do something different, because the more the tooth is tinkered with, it will push it further and further back. That in turn means a larger and larger incision and surgery to go up and get it. And teeth like this in this area typically will require a general anesthetic OR setting to remove, especially if they're carious. So again, principles: visualization and access, critical. Awareness, what are the anatomical structures? You have to think about what's around you, not just the tooth, not just the tips and tricks. You got to think about the entirety of the situation, not to mention the patient management. Technique and force. You know, you want technique, never force. And in addition, look at the patient and treat the patient, not just the teeth. So is this a nervous person? Is this someone that you think is going to move? Is this someone that you know is going to benefit from proper neurolept anesthesia? They're out and they're immobile for a difficult case, a difficult extraction. They will thank you for it. This is on Panorex, what it looks like to have a tooth in the infratemporal fossa as well. If you don't have access to a cone beam CT or medical grade CT in your office, this is what it'll look like on the pano. Retained foreign body and instrument failure complications. These are also common and interesting. So if we look here, you know, we can see that an instrument was left behind. Again, not a careless doctor, not someone who's trying to do ill will to this patient. It was an honest mistake. It happens. Right? And this was done during an extraction of tooth number 27 under local. You know, very, very reasonable treatment. So the extraction was conducted, the backstory. The patient returns back to the doctor, I should say, 3 weeks, complaining of chronic pain. It's unresolving, medicine isn't working, they're having infectious findings around the site. So what can we do to prevent this? Things like doing an instrument check at the end of the case, right? Paying attention not only to the tooth and looking at the tooth as it's on the table, but looking at your instruments, right? Making sure that they're all intact. What was this in this case? A suture needle. It was the tip of a suture needle that was stuck. It was driven into the bone. A lot of force, I guess, was used. The doctor went back in to try and find it. He couldn't find it. You know, we have a close relationship, sent the patient over, no problem. And we were able to remove it. So we took some imaging, you know, and like I said, during the case, if something's going awry, stop, assess the situation, think, you know, nothing is a runaway train, and then move from there, you know, how we're going to manage the case. And there's the needle itself on a gauze after I removed it. You can see here, we took a postoperative Panorex, the sinus is intact, and we were able to get it out of the bone there. This is an impressive case. Really needs no fancy arrows or anything to point out what's the matter there. So this burr was sent up, you know, trying to section that second molar there. And it was lodged and literally stuck into the posterior superior aspect of the maxillary antrum. And if we kind of draw a line across, you know, to more of the important stuff medially, it is kind of in line with the eye. So thank goodness, you know, it didn't go medial. Its trajectory was, you know, up and back. The orbital floor in and of itself is quite thin. It can be thin, almost like the lining of the sinus floor. And so, you know, these are things where doing an instrument check, not only to check that the instruments are intact after the procedure, but really making sure that your burr is screwed on. Giving it a little tug after you close the burr is a good little fundamental. It's hard. I know when you're rushed and you're behind, you know, it can be difficult, but it only takes one of these complications to occur to really ruin your day and you know, not do well to the patient. If you look here, we were able to remove the burr, and you know, the patient was fine, did fine. We closed it appropriately and did a buccal fat pad closure to close that communication. Speaking of which, the next complication is oral antral communication. Again, very, very common. The best way to review this is really to do it through a case study. And these are common things that I want you to look for after you do that standalone tooth, let's say, or you take out a tooth on the posterior maxilla. These are things that may clue you into thinking, oh, maybe there's a fistula there, and maybe we need to pay special attention to this patient. So in the history of present illness, we have a 60-year-old male. He came for an evaluation of a right oral antral fistula, referred to us for that. In his case, it was there for about 8 months. The tooth that was extracted was the 1/6. It was a standalone tooth, so a difficult tooth, upregulated in bone with internal loading. He denies pain to the site. Oftentimes they don't feel pain in these areas. But what he did say was it was bothersome during drinking and eating, and he had fluid emanating, you know, out of his nose, right? And as well as chronic nasal congestion and sinus congestion. So that's tipping you off into thinking, you know, what it is. Restorative plan, the patient wears a complete denture. And, you know, his diagnosis, he had a right OA fistula. And for him, we did a buccal fat pad advancement, adjacent tissue transfer, and closure of the fistula. And this is pretty cool and very common. So you can see here on the Panorex, you can see he probably should have had that wisdom tooth removed, but prior, but we took that out for him. But you know, there's the fistula. You can see the lack of bone kind of mesial to the remaining crown in the upper right side of the maxilla in the back, and right there. And we took a series of images, and you can see on the cone beam CT, there's a maxillofacial CBCT, you can see the lack of bone, okay, mesial to the crown on certainly axial view, you can see it on the coronal, and then in cross section there. And you can see the sinus inflammation of the Schneiderian membrane right there. This is what it looks like clinically. And if you'll notice, the appropriate setting for the vast majority of these cases is the OR, okay? You're gonna be able to have ideal lighting, ideal comfort for the patient anesthetic-wise under GA. You're going to have great hemostasis with a Bovie electrocautery, and you're going to be able to do a lasting, solid 2-layer closure, which I'll show you in the photos to come. That's going to last and hold up and really solve their problem once and for all. It's a one procedure, you know, one and done sort of thing to really help this guy out. So you can see the fistula there, the soft tissue, little undulation, and it's always bigger. Okay, it's always bigger in the bone than it is in the soft tissue. So there's the bone. You see the difference? So 1 and 2, right? And you can see there the buccal fat pad that we accessed as part of that 2-layer closure. This is the anatomy of the buccal fat pad, okay? So we're gonna be using, when we do this surgery, we're gonna be using the buccal extension of the buccal fat pad. And we dissect that out, and the technique is a submucosal dissection similar to a periosteal release that has been discussed in many of the other talks, okay? And you incise the surrounding fascia that's enveloping this pad, and they will herniate out. At which point we gently tease out the fat pad, making sure it's tension free, it's not pulling on the cheek, okay? And then we'll suture the fat to the palatal bone itself. Then we do an appropriate, and you can see that there, it's sutured underneath the flap. Then you do an appropriate periosteal release. In my hands, I like to use Dean scissors. Some people use, you know, blade, and that's fine. I can do both, but I like to use the Dean scissors. So you do an appropriate submucosal dissection, make sure you're not pulling on the cheek, make sure it's tension-free, and you close it in 2-layered fashion. And that's something that's gonna hold up and he's gonna be very happy with. Last little section here, as far as nerve injury is concerned, you know, this is a huge topic. I have a lecture in and of itself on nerve injury, nerve management, but it is important, and it is a fundamental knowledge that we need to at least go over a little bit in light of this topic. So we're gonna go over inferior alveolar neurovascular bundle, nerve injury, and lingual nerve. So to review, we've all seen this picture in textbooks in dental school and whatnot. This is a cross-section of a nerve, right? And you can see here, you know, we have the fascicles, we have the endoneurium, we have the perineurium and the epineurium. Why is this important? Well, when we're looking and doing nerve testing, okay, you test based upon nerve size to show you the degree of injury that has occurred, right? So, and we can discuss this at length, you know, at another time when we have more time. But this is why this is important. Based upon the nerve size and the type of fibers that have been injured, you will have different findings in your nerve monitoring. Okay, and there are two main classifications in our standpoint. I'm not going to, you know, belabor the point, but there's the Seddon classification, which I'm sure you've heard. There's three in the Seddon: neuropraxia, exondemesis, and neurotemesis. And then there's the Sutherland, and that's five, a more elaborate, different classification, but there is overlap, right? So just kind of the broad strokes, how to differentiate between exondemesis and neurotemesis. You can see 2 and 3. You know, the exondemesis is, there is spontaneous regeneration. Neurotemesis does not. That's a complete severing of the nerve, okay? The timeline is about 90 days. Now, the number one thing in this management is timing, okay? So you have to, if something has occurred, it's imperative that you have, you know, specialist backup and people that you refer to and work with, and you support them, they support you to really mitigate these situations, because they can be kind of a pain. So this is a nice case study. You can see here, you know, someone was trying to take out the 3.6 and 3.7 under local, and this is a case I did I managed during residency. I don't do this surgery now because the laws and the methods of doing the surgery for nerve repair in Canada are a little bit different than in the US, but nonetheless, it's good to see, and it's good to review the anatomy and to know when you're doing exodontia. So in this instance, teeth 3.6 and 3.7 were being extracted under local. 3.7 was difficult, and a handpiece was used, and the teeth were extracted, you know, and I'll draw your attention there so we can see the distal root there kind of coming in contact with the nerve, you know. And the patient developed symptoms. They started developing burning, dysesthesia to their lip and chin over time. So as we're tracking the nerve down, okay, after they were referred and they came to us with this issue, you can see here a track of granulation tissue. Typically, if you have burning dysesthesia, it's indicative of a neuroma, and I'll show you what that looks like in the slides to come. So here's a surgical site, okay? We did a lateral decortication of the mandible, and you can see the neuroma. That's what it looks like. So that is essentially the result of the tip of a burr nicking the epineurium, right, the outside of the nerve. And when they have a continuity defect, if the nerve is cut, typically they're numb, they have anesthesia. If it's nicked, they can have hyposthesia, or they can develop dysesthesia, in this case, a burning, sort of painful, shock-like feeling. So we decorticated the mandible. You can see, interestingly here, the mandibular canal, if you look at the inferior aspect of the nerve, okay, it's very dense and it's very hard. So the nerve is actually quite well protected. In this instance, we did what's called an external neural lysis. You free the nerve, okay, you dissect it out, which is very meticulous and painstaking. And you put, you know, I put the background there so you can see the neuroma. And then what you have to do, the treatment of a neuroma, if they're having these symptoms, is excision. You need to cut this area and reconstruct it. And that's what we did. So we excised the neuroma. We cut, you know, here and here, okay? And then here in the middle is, in this instance, we use an Incision nerve graft. This is a cadaveric nerve graft, okay, that is usually a sural nerve harvested from a cadaver and sutured into place. And then these are porcine conduits that we suture on with like 8/0 nylon sutures. And, you know, the patients tend to do fairly well. However, it's very, very unpredictable. This is a last ditch effort thing in someone who's in agony. And it's very difficult to find centers and surgeons that do this sort of work. So this is not necessarily like an incredibly reliable treatment, but it is something that you can offer them. Oftentimes, you know, they do have an improvement. It's very incremental, and they may be going from something like, you know, a burning dysesthesia to complete anesthesia, or, you know, a burning dysesthesia to a little hyposthesia. So it really depends. There's another photo. And then we put the cortex of the mandible back on after we decorticated. But this is cool because this is akin to some of the bone grafting principles we learn in implant surgery. So if you look in there, that's a GBR in there. That's a tissue engineering bone graft, which we used from BMP with a cellular collagen sponge, crushed cancellous freeze-dried cadaver bone. And in this case, we used PRP, platelet-rich plasma, okay? And we mixed it into bone graft, and we placed it in there. And down the line, you know, once the patient recovered, we did implants for him as well. This is kind of a cool case and a neat illustration of how the maxillofacial surgery informs oral surgery and can make you adept at doing these sort of procedures. And there's another photo of the bone graft. And then we closed. We used proline sutures, monofilament, to try and reduce infection. Lingual nerve. I'm not going to belabor the point because it's largely the same. But again, in lingual nerve, it heals more poorly than the IAN. Why? Because it's not in the bony canal. Lingual nerve is in soft tissue. So it's more important that they get seen early. And ideally, it's important, you know, that we take the time, treatment plan the case, and don't go after these cases that are going to have high risk of this. Don't poke the bear. It's really not worth it. There's a plethora of cases, and so the best way to prevent these sort of complications really is avoidance, because if it gets to this point, it is fairly unpredictable for the patient, and they're usually pretty unhappy. So just kind of some brief points on the anatomy of the lingual nerve. We kind of talked about it in the intro slide with that schematic, but basically, you know, the main take home that I want you to take away from this is the height of the lingual nerve. We talked about 10 to 15 millimeters at the crest, crossing over in those patients, and 25% of cases, the lingual nerve is stuck onto that lingual plate of the mandible. So it's imperative that we keep it intact. We don't break the lingual plate. We don't carry a burr posteriorly. All of those things are important when you're taking out molar teeth or whatever you're doing back there. And this case in general. 4/8 was extracted under local from the GPR clinic. They had some burning pain and dysesthesia to the right tongue, and that was there for 3 months. That is low success rate. Usually you want them in lingual nerve, you know, as soon as possible, a month ideally. 3 months is the maximum window. That's when we got to this patient. That's where it occurred. This is a angiocath showing isolation of the nerve. And there's the neuroma itself. You know, you don't have to be a microsurgeon or whatever to know that looks pretty bad and ugly. And that's, you know, that area, that little ball is the neuroma there. And we excised that. And this is important. So you see the neuroma is under 1 centimeter in size. So when you excise the nerve and excise the neuroma, if it is less than 1 centimeter, you don't actually have to use a nerve graft. You can just put a conduit there. And that's what we did. This is a further case. So there you can see the conduit sutured in place. This is a further case, just kind of illustrating, I just included it for completeness sake, just showing the nerve and cross section, how you can track it. You know, towards the defect, which is that black radiolucent area. Again, we isolated the nerve. There's the neuroma there with the background. There is the nerve graft because it's larger than 1 centimeter. We put the conduit in, sorry for the quality of the photo, and then put a plate on in this instance for the decortication because it was a little bit of a tougher spot. And that's really it. So thank you for your attention. I know I kind of covered a lot and talked a lot, but I hope you sincerely enjoyed it, and thank you very much.
Awesome. Thank you so much for that, Chris. That was absolutely incredible. Well done. And you blow my mind every time that I see the work that you do. So hats off to you. Couple of housekeeping items real quick before we start wrapping things up with the Q&A aspect. If you haven't done so already, please make sure that you type in your name and email address for CE verifications. CE certificates from last week were, I just saw, I checked in my email, they were sent out. along with we've posted a lot of the videos from last week as well. A reminder for tomorrow, May 21st, we have at 11 a.m. Dr. Jazz Takar, who will be talking about his implant journey, so make sure that you all tune in. It'll be followed by Dr. Ho-Young Chung, who will be talking about everything that you need to know about implant locators. So as always, make sure that you register at dtacademy.ca, and the password is track all caps 20. We're going to go ahead and pass things on to Ziad Hamad for the Q&A ask.
Chris, I got to say that was an unreal lecture. I mean, I know I speak for a lot of us young grads. There's a lot of great tips there, especially complications. So thank you for that.
Oh, no problem, buddy. I thank you for your attention. Thanks for being patient with me in the beginning. I had some technical difficulties, so thanks for that.
No, you did great. You killed it. So starting off with the first question by Ruda Al-Rahani. So she's asking, you always take patients off blood thinners for any number of planned extractions. And we had a follow-up question as well. The person was asking about, how about the newer anticoagulants? Do they need to be stopped before surgical procedures or not?
Great questions. Excellent. So a few things. It depends on what you're doing for the patient. In general, multiple extractions in the literature is 3 or more. So if you're going to take one tooth out, okay, and it's likely not going to be surgical, you don't have to stop any blood thinners. You know, you don't have to. If you're going to do a full clearance, like an MOA sort of procedure, then it's more reasonable to consider that or stage it over time. So if it's a single tooth, you don't need to stop the blood thinners. If it's aspirin, you typically don't need to stop the blood thinners. As far as the new generation drugs, the novel new anticoagulants, I would consult with the physician, but typically even with those, they're not stopped. We'll stop like a morning dose, let's say, or an evening dose if it's multiple teeth, right? But it's typically an older patient. It's usually a little bit harder on them. So stage it. If you can fit it in your schedule, that's what I would recommend.
Okay. So the second question is, during the extraction of a maxillary third molar, assuming the tuberosity is fractured and the tooth with the tuberosity remains attached to the surrounding tissues, the soft tissues, what should we do?
So typically you're not going to see the bone and the tooth are intimately attached, right? If you can manage to get the tooth out and the bone is loose, but it's still within the soft tissue envelope, it'll likely heal. It's only when you're using excess force, you pull the tooth out and the bone comes along with it attached. It's now been devitalized. It's lost that periosteum that I showed in the diagram, and they'll have that defect there. So if you can manage to get the tooth out and it's fractured, but it's still within the soft tissue envelope, it's okay. It's at the point where the bone is visual on the table or in your hand, that's a problem.
Okay. So the next series of questions are regarding oral antral communications. So, so what would be your immediate management for OACs? And Omar Dejani is asking as well, what suture would you use to suture the buccal fat pad to the bone? And the third question follow-up as well from Dr. Murad, how long would you wait for the tooth / root in the sinus to fibrose before going in to remove it?
So I'll do one at a time. As far as OA fistula is concerned, you have to evaluate the size that you see at the time of the procedure. Typically the books say about 7 millimeters, just about. If it's under that, it's probably going to heal. Even if it's 7, it likely will heal. Just bring the patient back on a recurrent basis to follow up, right? So that is your indication as far as your immediate management. You're not going to close it immediately if it's a reasonable size because it's likely to heal, right? If it's very large, as I was saying, the ideal setting to do a buccal fat pad surgery is the OR. I've done them in the clinic. It's fine, but it's much, much better. They're going to have a lasting result in the operating room. So that's a case you want to call your surgeon. They'll work in tandem with you. You can book them in the hospital and we'll take care of it appropriately, and that's fine. That happens, The suture I use, to go through the bone. It depends on how thick the bone is. So sometimes you have to put a burr hole through the bone. That's why I'm saying the OR is a necessary place. Sometimes you have to drill, a hole into the palate to hook the suture around and come through. You could use a Vicryl. You could use, something robust, PDS, something robust that's going to stay there, resorbable, but will stay for some time. And then you close the mucosa.
And I think that third one was how long do you wait to let the root fibrose?
The root will fibrose typically in about 2 to 3 weeks, right? In that instance, again, to do a Caldwell-Luck, it's probably best to do it with ideal lighting. You don't have to do it in the OR, but I would recommend doing it in the operating room, because if it's pushed somewhere far back and you have to go in there and dig for it, you don't want to be getting into the sinus or getting into a situation over your head in an unsafe environment. Have the ideal lighting, have the ideal instrumentation, and the electrocautery, the Bovie, if you need it to control bleeding, right? It's going to give them, as opposed to just trying it, having it not work out. Now the patient's, losing confidence. The extraction already didn't go well. Now the retrieval didn't go well, and they're feeling beaten up. They're not trusting the solution. It gets back to that reputation piece, right? You have to do things that, and I think it's our responsibility to do things that are predictable, right? It doesn't have to be perfect. No one's perfect, but we have to have an idea of how predictable things are and work with people that, if you want to learn that, will help you and get you there.
To add to that, Chris, Basil asks, when you mention the size of the OAC, do you mean the size that you can visualize in the soft tissue, or is it the size of the palate, since you said that it's much larger in the bone?
The great question, Ishan. Good follow-up. It's the bone, because what that is like you're looking in the socket and you see the hole into the sinus. You'll see a black hole, right? So, and if you're worried, if you're concerned, like I said, use your assets, make a team, call your oral surgeon, say, hey, listen, I did an extraction. Here's the x-ray. I'm kind of worried about it, and talk through it. You don't have to, no one is an island. And that's at least what I think is reasonable. And that's why I say that. So.
Awesome. Thanks, Chris.
Yeah.
And the next question is, what is your case assessment criteria for each tooth that you're extracting? What do you look for radiographically and clinically to help you visualize the tooth extraction? And on another note, what other factors do you look for when you assess wisdom teeth extractions?
Excellent question. So I'll do one at a time. It gets back to that slide I showed, right? That algorithm when I showed, so I'll just kind of reiterate that, because that's, how we approach it. So you're going to look at the tooth itself. You're going to look at the root structure of the tooth. Are they flared? Are they narrow? You're going to look at the age of the patient, right? Sometimes ethnicity plays a role. Some ethnicities have denser bone than others. Not always, but sometimes. You're going to look at if they have tori, if they have exostoses. That's upregulation of bone because they're clenching, they're grinding, right? You're going to look at the tooth itself. Does it have endo? Is it endo-treated? Is it difficult, right? So that's something that okay, this is going to suck a little bit. It's going to be difficult. I'm going to book more time in my schedule, or I don't want to deal with that because I have other stuff to do. I have many other patients. I'm going to refer that case out. It's up to you, however you want to play the game. And that's why I use the Jordan analogy. Wisdom, and then the other, I should say too, and then I'll get to wisdom teeth. So it's the clinical, but it's also the person. Is this a nervous patient? Is this someone that's going to be able to tolerate the added time of me working on them? Are they scared? Are they going to move and thrash and open me up to possible complications that are hard to control? You have to think about those things too. Wisdom teeth themselves are more complicated. There's a lot more nuance to them because there's more vital structures around them, right? More can go wrong. They can be close to the nerve. So some of the principles of assessing the root is fine. The bone quality is fine. You have to look at the proximity to the canal, the degree of impaction, the angulation of the tooth, things like that. Proximity to the sinus. And then the patient management too. Can they tolerate that? It's very comfortable to have neurolept anesthesia, teeth are out like that, and the patient is still and their swelling is minimal and whatnot. Not all patients need that, but it's up to us to quarterback that treatment.
Okay, that's great. Another question, anonymous. Is there, if there is a paresthesia after an extraction, how long should we wait for the nerve to recover on its own before we refer to an oral surgeon for intervention?
Great question. So it gets back to that timeline slide that I had as well. The maximal amount of time is 3 months, 90 days, right? You know, the nerve section was not intended to be a definitive management sort of thing because I don't have the time to do that. I can do another lecture on that in detail. But in general, you know, it's about 90 days for IAN. Lingual nerve is less. Why? Because it's in soft tissue, right? So there's no bony canal to redirect that growth. You know, oftentimes when you refer to an OMFS, they may not be your saving grace and be able to fix everything and make the patient perfect again if the damage is significant, right? So that's why I was saying the most important thing to the success of your practice and your reputation and predictability is spend time looking at the case, anticipating as best you can these sort of nerve bad complications. And then if you have questions or you're worried or you're concerned, have a friend, have someone who does this all the time and can guide you and you can learn. It's just my impression, my take.
And another follow-up on paresthesia after an extraction. So what are your thoughts on prescribing a steroid to a patient after they develop paresthesia from a block? And if so, what would you prescribe?
Well, steroid, that's a great question. Steroid is absolutely great to prescribe after nerve injury. It's one of multiple things that you can give the patient to help, medicinally recover. So that's fine. And, but from a block in and of itself, usually it's transient. It's very, very rare that a block will give you paresthesia. Where you're going to get nerve injury from a block is if you insert to do your IAN block and you're moving the needle. You have to think of I was taught by Malamed at USC. I was very lucky. If you're moving the needle, sounding the bone or doing multiple pokes or swinging it, okay, that's a little scalpel in there. So that's where you're going to maybe have a problem. So if you want to redirect and they're not getting numb, you go in, you inject, come out, and then go in again, right? Don't go in redirecting the tissue. If you poke them multiple times, it's okay as long as they're frozen, after you inject on the onset of your procedure. And one other thing I didn't mention, always test your patients. If it's local, I test every single patient. Test, make sure that they're feeling pressure. Don't hurt anyone. If it's a tough tooth, again, have backup, have people you can send the patient to so they can get the tooth out and you can move on with your treatment plan and do, the bridge or whatever you're going to do for them.
And we actually got about 3 more questions left. Going back to the sinus, when can we leave sinus perforation alone and let it heal along after its extraction?
Great question. I guess everyone wasn't asleep during my lecture. I got some questions. Good. So sinus perf, right? Again, it comes back to what you see when you take the tooth out. So if it's a reasonable sized connection, okay, 7 millimeters less, that sort of range, I'm still going to be concerned. I'll still bring the patient for a follow-up, but I know their chance of healing is higher. If it's a larger defect, with experience now, just taking out tens of thousands of teeth, we're going to watch them closely. They may need a buccal fat pad, right? Timeline, I would bring them back on a recurrent basis, at least for a month and a half, and make sure, 1-2 appointments, and make sure they're doing fine, and give them sinus precautions, right? That's very important. Try, it's unreasonable, but try your best, sneeze with your mouth open. Don't bend your head below your waist. Don't pick up super heavy stuff. You can give them a decongestant if they're having sinus, congestion. And again, just it goes without saying, have backup, have friends that you can call, people you refer to here and there, have that relationship, and they're going to look out for you and help you. It's insurance, and it's good for the patient.
Awesome. And the next question is, what are the anatomical structures, blood vessels, nerves that should be taken into consideration when designing a flap? And it says, I mean the ones that can be injured if they're in line with the incision, besides the mental nerve and the lingual nerve.
That's pretty general. So as far, so we're blessed as dentists, oral surgeons, all like us collectively, where we work anatomically, right? The blood supply to the mucosa is pretty excellent. So generally the mucosa in the mouth has multiple perforators, okay? It's not just one distinct vessel that you're going to nick or cut into for the vast majority of cases. So it really, I know it's kind of a vague answer, but it depends on where you're working, right? We talked about a ton of different blood vessels, the posterior superior artery. You're not going to get into that unless you have a buccal plate fracture. We talked about facial, very hard to get into, but it's possible if they move or you slip, right? The mental itself, you just avoid it. And we can talk about that, between the premolars at a different lecture. So the oral cavity in general has a pretty robust blood supply. You're not really going to get necrosis. It's more if you damage paper thin tissue, like for example, in the lingual aspect, you'll get exposed bone, and you really have to respect that tissue because it's very thin.
And
I know it's a vague answer, I'm sorry, but it's a vague
No, that was great. That was actually great. So, and the last question we got is also anonymous. And the question is, during an extraction, how would you manage bleeding from the facial nerve? I think they meant facial artery. From the facial artery, facial nerve, or like palatal artery.
Yeah, they probably mean DP too, right? Descending. Yeah. Well, number one principle in stopping bleeding is pressure, and we know that, right? Number one is you want to put your finger on with gauze and hold it for like 5 minutes with pressure. Number one. Secondarily, it depends. It's a good question, but it depends on the size of the vessel. So as a surgeon, okay, you control bleeding in different ways. If it's a large vessel, it's completely different. If it's a facial artery sort of issue, it's large enough you can see it. You'll get in there you'll dissect it out, get in there with a hemostat, okay, and you got to tie the vessel off, right? Most people in their office don't have clips, right? So you find it, you clip it with a hemostat, and then you'll suture the vessel. And we do that in our training when we're in the neck, right? For different approaches to the mandible, bone grafting, cancer, stuff like that. For smaller vessels, if you get into like a bone bleeder, like I showed in the Haversian system, pressure is one. Two, you can kind of crush the bone. And that's a common knowledge thing that a lot of people know too. You crush the bone over the little bleeder. Sometimes they can be pulsatile to close it, control it. If you're, again, have someone on speed dial, call them. If you're reliable with them, they can help. You know what I mean? So it's important, as you're venturing and pushing yourself and doing these things, you want to do it in a predictable way. You want to do it in a way that you feel good about what you're doing and it's going to work, right? So.
That was great, Chris. That was all the questions we got.
Yeah.
Thank you for that.
I talk a lot, man. Sorry.
No, thank you so much. Yeah, that was very, very good. One more quick housekeeping item. Remember tomorrow to tune in at 11 a.m. where we have Dr. Jastikar. We'll be talking about his implant journey. Every one of you young dentists, somebody who's just trying to learn how to place implants or restore implants, or somebody who's just graduating, make sure you tune into that one. As I mentioned, he's got so many pearls and he'll put you on that path of success when it comes to implant placement and restoration. Following him, we'll have Dr. Ho-Young Chung, who will be talking about locator overdentures. So make sure you tune in tomorrow at 11 a.m. And just as always, dtacademy.ca to sign up. And our password is track20, all caps. We'd like to thank our speakers for today, Dr. Matt Morrison and Dr. Chris Finelli, for such incredible presentations. Thank you guys so much for your time. I did leave both of their email addresses on the chat lines as well. So if you guys want, please feel free to reach out to them. If you want to talk about a case or if you want to refer them a case, their email addresses are there. And they've also discussed about to you guys exactly where it is that they practice. I'd like to thank our co-hosts for the day as well, Dr. Michael Rondinelli and Dr. Ziad Hamad. Thank you so much for those great questions. And thank you everyone for joining. Stay safe, and we look forward to seeing you all tomorrow. Have a great day, everybody. See you.
Thank you so much.
Thank you.